I am going to share with you a presentation which I made in 2003 and presented in DOS. That time also I was having an affair with SICS, and then Phaco. I had started doing Phaco and reasonably well, and the pressures of a private practice were telling on me. But because I held SICS so close to my heart, there was this presentation I made which was showing the similarity in the concepts and the skills and perhaps comparable results. So, to my mind, comparison is a very foolish attitude, and every surgeon is unique. Every surgery is unique and incomparable. But when we look at the concepts and skills and evaluate a surgery in terms of its results, then we'll be able to look at it. There's a general tendency of Phaco surgeons and SICS surgeons trying to pull the other people down. The SICS surgeons, just because the surgery is not done with too many instruments and fancy equipment, feel that they need to bring up the level of their discourse in SICS, whereas the Phaco surgeons never look at this beautiful surgery at all. So, yeah, you can see it now?
Yeah.
So, the beauty of a surgery lies in its reproducibility, the surgeon's skill, and at the end of the surgery, the surgeon actually having enjoyed the surgery. This sclerocorneal tunnel formation, you're putting in a constant effort in making the incision size small within the astigmatic free tunnel, this zone, and bringing down is a matter of skill, and it varies with person to person. But same way as we learn and have a learning curve in every surgery, this surgery surely and surely, SICS, is a stepping stone and perhaps a superior surgery as far as the skill is concerned vis-a-vis the incision. We earlier heard about the amount of astigmatism and how it is controlled by various surgeons. The beauty lies in this lovely incision. Yeah, the side ports and learning how to do the side ports. We know now SICS earlier when we started off doing SICS, or what we called at that time, we used to call it a modified extracapsular surgery. We were not using the side ports too much. Most of the surgery was done through the main port. But we know that this is a very essential part of doing a good cataract surgery. I'm sorry. So anybody who is doing an SICS and is getting used to making a larger capsulorhexis is going to make any size capsulorhexis, because we know that a bigger size capsulorhexis is always difficult to make. So this is perhaps, again, as far as skills are concerned, higher degree of skill, because you are able to make a bigger rhexis. In phacoemulsification, perhaps many people feel that you need to have a capsulorhexis which is good enough, safe enough for the safe phacoemulsification, but at the same time covering the edges of the lens. But in CCC, we are always aiming at a bigger size rhexis. So that's again a matter of higher level of skill. And hydro procedures, perhaps critical to both surgeries and perhaps more critical to SICS. Anybody who is doing SICS and doing a beautiful hydro procedure is going to do it very easily in a phaco procedure also. So I personally feel here again, the SICS scores over phacoemulsification, because here the hydro procedures have to be more delicate and better. And then the target, the nucleus. There is no confusion that SICS can deal with any nucleus. Whether it's a soft nucleus, a hard nucleus, a rock hard nucleus, it can deal with anything. while as the energy which we use during phacoemulsification for handling the hard nucleus is always an issue in phacoemulsification. We can see that both surgeries are done with a lot of awareness regarding the endothelium. But if you're doing a viscoelastic and doing a nice SICS, knowing a well-controlled SICS, perhaps the endothelial safety is very, very comparable. In fact, the higher the degree of the hardness of the nucleus, the more is the mauling of the endothelium in phacoemulsification. And when we're talking and comparing these surgeries, you also have to look at it at different times of skill development, whether it's a postgraduate or a resident, senior resident, or a person with a lot of experience, and you take that same thing for a phaco surgery, you can see that SICS perhaps is more forgiving in those matters. And we know in both we can have a closed chamber IA irrigation aspiration. But in SICS, you obviously have the advantage of being able to go through the main port also if there is some sub-incisional cortex. Perhaps that difference or that superiority in SICS has reduced by introduction of bimanual IA in phacoemulsification also. But in SICS, obviously, you can use any lens you want. Any lens you want. We just heard about different people, different surgeons using multifocals, torics, and PMMA lenses, cheaper options. But in phacoemulsification, perhaps your options are limited and you are not able to have such a choice as far as lenses are concerned. And obviously at the end of the surgery when you remove your viscoelastic. So I always felt that even if there were people who were learning phaco, it would be nice if they would master their SICS. And because there will be situations where you will always need to come back to SICS, even if you are a very proficient phaco surgeon. And to my mind, when we are comparing surgeries and showing the superiority of phacoemulsification over SICS, I personally believe that these are both surgeries which should be there in the armamentarium of any surgeon. And in our sort of environment situation where we have to deal with less finances, perhaps it is not right to speak about SICS as a surgery, as a poor man's surgery. It's a beautiful surgery. It perhaps needs more skills in certain ways, and the concepts are very comparable and the results are very comparable. So best thing would be to call one surgery awesome and the other one also awesome. And I still love my SICS, though most of my surgery is phaco. Thank you all for your kind attention. I'm surely hoping that someday we are able to have a meeting in Kashmir, and especially in a weather like this. It would be a fascinating thing. We hope we get over COVID. Thank you very much.